Hello, good day, good afternoon, good evening. Thank you very much for joining us today for our webinar on non-sedated pediatric ERG testing in your office with the RETeval device. My name is Andrew Jones, and I'm the VP of Sales for LKC Technologies. Before we get started today, I wanted to take you through the question feature that exists in the GoToWebinar. GoToWebinar is this question function is what we're going to be using for handling questions today. So all you need to do is, if you'd like to ask a question during the presentation, open up your control panel, which is the orangish arrow pointing to the left. Open up the control panel, open up the question box, type in your question and hit enter. Your question should appear in the box, and our plan is to stop several times during the presentation to answer any questions that you may have. So without further ado, what I'd like to do is introduce our speaker for today, Dr. Victor Pegado. Dr. Pegado practices pediatric ophthalmology on Vancouver Island in Canada. After graduating from the University of Toronto School of Medicine, he completed his ophthalmology training in Vancouver at the University of British Columbia. Previous training included undergraduate studies at McMaster University in Hamilton, Ontario, where he was also born and raised. Dr. Pegado completed his fellowship in pediatric ophthalmology and strabismus at St. Louis Children's Hospital, Washington University in St. Louis, Missouri. Dr. Pegado is both a fellow of the Royal College of Physicians and Surgeons of Canada and is board certified by the American Board of Ophthalmology. He is also a member of the American Academy of Pediatric Ophthalmology and Strabismus. Dr. Pegado is a clinical assistant professor at the University of British Columbia, Department of Ophthalmology and Visual Science, and also at the Island Medical Program in Victoria, British Columbia. He also provides medical and surgical care in Fort St. John, located on the Alaska Highway, and Haida Gwaii, a remote island also close to Alaska. Thank you very much, Dr. Pegado, for presenting today. I'm going to hand things off to you, and I'm really looking forward to seeing your presentation today.
So yeah, good morning, everybody. So I've been told that there's attendees from 46 different countries. So I guess good night to some of you. I hope you're all keeping well and safe, no matter where you are. And I hope you, your families, and your patients stay healthy during these unprecedented times. As mentioned by Andrew, I'm a pediatric ophthalmologist in Victoria, British Columbia. I have mostly a community-based practice, and I incorporate a small amount of general ophthalmology. After not performing any surgeries over 2 months, surgeries are starting up this week in my community. I experienced a new reality when I returned to work. This involves significantly reduced volumes to help deal with patient distancing and COVID-related protocols. These events often help us reevaluate our practice patterns. I find myself enjoying patient encounters a lot more when there are less time constraints. This increased time with patients may allow for increased opportunities to adopt and use new technology, including electrophysiology. So today I'm excited to share my experience with the RETeval unit, and I hope to shed some light on this sometimes daunting topic. So it's always a good start to go to basics. So the ERG measures the electric response of various cell types in the retina. On the left of this slide, we have the anatomical and physiological representation of a light stimulus. On the right, we have the electrical response to a light flash, as measured on the skin just beneath the eye. The rods and cones in the retina absorb light and convert it into an electric response. This is a corneal negative electric response resulting from hyperpolarization. This is known as the A wave. The photoreceptor response causes neurotransmitter release to bipolar cells, which creates the latter half of the A wave and all of the corneal positive B wave. The bipolar cells effectively transfer information from rods and cones to the innermost cellular layer, the retinal ganglion cells. The retinal ganglion cells are responsible for carrying visual information from the eye to the brain. This is known as the photopic negative response wave. The RETeval can measure all three waves. Here we have another schematic demonstrating the different cell types and the corresponding ERG waves. Again, the A wave represents early signals from rods and cones. The B wave is created primarily from rod and cone on bipolar cells. Oscillatory potentials, although poorly understood, can be measured by the RETeval They are thought to arise from amacrine cells. The RETeval can also measure the photopic negative response, which is a measure of ganglion cell function. Glaucoma experts often use this wave. And there's also a late D wave generated by off bipolar cells. So some common concerns about ERG include: 1, that it is a last resort option; 2, that it requires sedation or general anesthesia; and 3, that it is time consuming. I've been using office-based electrodiagnostic testing for over 10 years. I've used the RETeval unit for about 5 years. Prior to obtaining office-based ERG and VEP, I rarely requested testing. There were numerous reasons. I practice on Vancouver Island, and testing would require a long trip for patients. Sometimes traveling and waiting for tests would be time consuming. Reliable testing in young children often requires sedation, and sometimes parents were not keen on sedation or general anesthesia. The thought of having a full electrodiagnostic setup in the office seemed like it would be helpful for patients. However, the expense and the need for a specialized technician made this impractical. Electrodiagnostic testing in a hospital setting is also quite time consuming, and including the time to dilate patients, it can take over 1 hour. This would also be very difficult in a busy community-based practice. So along came office-based electrodiagnostic testing, which dispels many of these concerns. I'm very happy with the RETeval. The learning curve is steep initially, but once you are over it, the information received is invaluable, and continued use and interpretation becomes very easy. Okay, so a lot of information on this slide. So the RETeval is the first and only FDA cleared non-mydriatic handheld full field ERG VEP device. Fixation is not required. It works with media opacities, meaning it can generate responses through dense cataracts that we cannot see through, or even through a newborn's closed eyelids while they are sleeping or crying. Point 3, portable, powerful ERG testing in the palm of your hand. This is a big deal. This device can travel between rooms in the office. This can easily be carried to the operating room or when I travel up north to do remote clinics. I don't have cameras or OCTs in some of these places. I'm sometimes lucky if the slit lamp works. In the middle of nowhere, I find myself doing ERG and VEP testing on infants with nystagmus, and I am able to get a reasonable sense of whether retinal function is normal, borderline, or abnormal. 4, the RETeval can measure and compensate the light according to the dynamic pupil size to ensure consistent stimulation of the retina regardless of pupil response. 5, the unit has a simple interface, report generation, and automatic analysis. This makes it easy for staff with minimal experience to learn how to use the ERG. I have 3 staff in my office who are all capable of using the RETeval, including a pre-medical student. Testing can be quick. If you want to do a flash and flicker ERG, this can be completed in minutes, and you will quickly get a sense of whether photoreceptor function is normal or abnormal. If testing and/or the clinical exam suggests retinal dysfunction, this little unit can provide full 5 or 6-step ISCEV compliant dark and light adapted testing. This type of testing will obviously take longer. I usually perform testing with an eyelid electrode, which negates the need for sedation, but I have also used the unit with jet contact lens electrodes, resulting in increased signal strengths and lab quality recordings. So this slide demonstrates the interface. Patient information can quickly be scanned by the RETeval unit, which can read QR codes. This makes adding patient demographics fast and simple. The eye is visualized on the screen as seen in the top right corner. The patient looks into the Gansfield stimulator. The RETeval has an eye cup that can be cleaned or swapped between patients. The inside of the unit can be wiped and cleaned. The sensor strip, which is disposable, is placed below the eye as shown in the figure. So here I am as a patient with a jet contact lens electrode. Topical anesthesia was required, but as you can see by the smile on my face, it's reasonably well tolerated. ERG recordings with the contact lens are usually not necessary, but if we have a patient with early disease or borderline results, this contact lens can sometimes make a difference. The quality of these recordings are incredible and are on par with hospital recordings. So now going back to those physician concerns about ERG and VEP in pediatric ophthalmology, that it is only a last resort, that it requires sedation, and that it is time consuming. Having the unit in the office and the ability to use it on non-sedated children has moved the unit from being a last resort option when every other diagnostic tool has been exhausted to sometimes being an early diagnostic tool. Newborns and infants up to 3 are difficult to image, whereas ERG testing can sometimes be easier. So I hope this presentation helps to inform you all that this can be a routine test, that it requires no sedation, and that it can also be done quickly. So many of us will remember that of all the different electrodes that can be used for ERG testing, that an eyelid electrode has the weakest response. These eyelid electrodes have obviously improved, and with the addition of signal averaging, waveforms are surprisingly strong. So Bradshaw and colleagues compared ERG waveforms recorded with skin and corneal electrodes in healthy children and adults. They found that the recorded amplitudes are lower, as expected, with skin electrodes. However, the waveform was comparable to corneal electrodes. By using the difference in B wave amplitudes between the sensor strip and DTL electrode, the entire sensor strip recording can be normalized. When this is done, you can see how the smaller waveform in figure A takes on an almost identical waveform to the DTL recording in figure B. So most of the information captured in standard lab ERG testing is present in the eyelid tracing. We just need to look for it. The RETeval has 2 different stimulation protocols. The Candela protocol is used in dilated pupils and results in constant luminance for the duration of each test. The Trollin protocol is designed for patients who are not dilated. It uses varying luminance based on the pupil size so that the retina receives a constant illumination for the duration of the test. The Trollin protocol can be useful in a stubborn child or adult who refuses dilation. In our practice, the Candela is almost always used in children because the pupil tracker and a moving child don't always mix well together. So in a moment, I'll be going on to the interesting part of the presentation, which is the case studies. But I think I might stop here and ask Andrew if there's any questions out there.
So Dr. Pegado, no questions so far. So we can go ahead and move on to the cases.
Okay, so this is where things start to get interesting. So there are several clinical examples in this presentation, and I think you will find these cases, again, quite interesting. They all come from my practice here in Victoria. So the first is this 4-year-old boy without nystagmus who presents with decreased night vision and visual acuity measuring 20/100. So looking at the retina, the appearance is suggestive, well, there's suggestion of optic nerve pallor in both eyes, and the arterials appear attenuated. There's also a tigroid appearance to the retina in keeping with a refractive error of -10 in the right eye and -7 in the left eye. So we performed electrophysiology testing on this patient. The 30 Hz flicker test, which tests cone-related retinal function, is a very quick way to establish that something is wrong with the retina. Here you can see the significant reduction in flicker voltage. Amplitudes less than 5 microvolts correlate very high with cone system dysfunction. This 5 microvolt cutoff will be discussed later as well. So to contrast this abnormal ERG, I enlisted my daughter. So this is her 30 Hz flicker test. Her recording, thankfully, is normal. Compared to our patient with voltages less than 5 microvolts, the ERG here demonstrates amplitudes of 30 microvolts, 40th percentile. And her implicit time is 85th percentile. I guess she's a high achiever. In general, we are not concerned with quick implicit times, but long implicit times are concerning. The diminished flicker ERG can be seen in both cone dysfunction and retinitis pigmentosa. Knowing that this patient actually has a family history of Bardet-Biedl syndrome obviously points us in the direction of retinitis pigmentosa, but we should still take a look at the remainder of the ERG. Observing the results of dark adapted testing should help us confirm the diagnosis of retinitis pigmentosa. Okay, so here we go. This is where things start to look pretty complicated, but trust me, it's not that bad. As you can see, the ERGs are almost extinguished in all 4 ERG tracings, which is consistent with a diagnosis of retinitis pigmentosa. Tracings numbers 1 to 3 are dark adapted, with number 1 being the dimmest stimulus and number 3 being the brightest. 4 represents the light adapted flash ERG. Cone disorders, which were on the differential based on the flicker ERG being abnormal, would generally show a better dark adapted rod response than what we see here. Again, the extinguished ERGs across the board is in keeping with the diagnosis of retinitis pigmentosa. So here, this is a published case of a RETeval ERG recorded from a 5-year-old boy with retinitis pigmentosa. The demographics and results are almost identical to those obtained on our patient, which we just looked at. The ERG responses were almost extinguished under both scotopic and photopic conditions, and it was confirmed that this patient had retinitis pigmentosa. Normal results are shown underneath, so you can get a sense of what a healthy response should look like. Using the ISCEV standards, starting at 0.01 candela stimulation, only the rod response will be elicited. This is seen on the left, and you can see that the response is virtually extinguished in the patient with RP. Because the eye, so increasing to 3 and 10.0 candela will generate a response from both rods and cones. Because the eye has roughly 10 times more rods than cones, the dark adapted response is primarily from the rod pathway. In a light adapted eye, a standard flash of 3 candela elicits an early A wave indicative of cone function followed by a positive B wave indicative of bipolar function. That's what happens in a normal eye. Again, in our result, it's extinguished. And in a normal light adapted eye, a flicker ERG, seen on the right, elicits a response from cone bipolar cells. As mentioned earlier, only cones can regenerate their retinal response to keep up with a 30 Hertz stimulation. So here, the RETeval was able to identify retinal dysfunction. It was able to demonstrate both rod and cone dysfunction, and was able to help confirm a diagnosis of retinitis pigmentosa without genetic testing. The differential for a fully extinguished ERG is narrow and also includes Leber congenital amaurosis and a total retinal detachment. A CRVO or vascular event would also cause an extinguished ERG. So I might stop again and see if there's any questions out there.
Yes, Dr. Pegado, I have a question from Donna Bong. She's asking, how long do you dark adapt a child, and how long do you light adapt, and how do you light adapt a child?
So the ERG allows you to dark adapt using the unit itself over the patient's eye, but generally we put the patients in a dark room. We'll put the ERG electrodes on the patient before we dark adapt them and have them and their parents sit in a dark room for 20 minutes, usually before the test begins. And then once the test starts, you have the option of doing dark adapted first using the RETeval, or you can do a light adapted first, in which case you'd start off without any adaptation to light because all they need is room light. But the ERG unit actually guides you and has timers that tell you exactly how much time to wait between tests. So it makes it very easy. But the fact that you can just put the lid electrodes on your patient, turn off the light, go see a couple patients, and then come back to the room and move on with the test makes things pretty usable. And you can do this in any room you like, so you don't need to have a dedicated ERG room.
All right, thank you, Dr. Pegado. I'm not seeing any other questions, so we can go ahead and move on to the next slides.
Okay. So based on several studies, including a study by Liu et al., the RETeval has been shown to have reasonable diagnostic accuracy in comparison with the clinical full field ERG, while exhibiting a high degree of sensitivity and specificity. This study performed RETeval and classic lab full field ERGs on normal and abnormal patients and looked at how the results compared. As you can see, the RETeval results compare favorably and similarly to the full field hospital-based ERG tracings. So the hospital tracings are shown below, and the RETeval tracings are shown above. And just, yeah, looking at the waveforms and the pattern, you can see a remarkable similarity there. For most of the tests, there is an age-adjusted database for both voltage and implicit time. Green is normal, yellow is cautionary, and red is potential problems. When starting out with the RETeval device, this makes interpretations easy. So here's a list of common uses of full field ERG testing in pediatric patients. Many of these conditions are obviously rare. Is it really necessary to have this test for these conditions that we do not see very often? So I actually find the unit to be invaluable when looking at patients who have odd retinal appearances, unexplained reduced best corrected visual acuity, or testing vision in children who are nonverbal or non-reliable. A normal ERG and VEP from the RETeval is also reassuring in patients who are malingering. The majority of tests that I perform are probably normal, but still reassuring to myself, the patient, and to parents. Another group of patients where ERG testing can be very helpful are those with nystagmus. These are usually infants who are difficult to image. Aside from our clinical examination and indirect ophthalmoscope examination, there are sometimes few additional clues. Our initial goal is establishing if there is a sensory issue. The retinal exam in some of these diseases can show no findings or subtle findings, so the ERG can sometimes shed light on the diagnosis. So case number 2 are 2 siblings with presumed congenital motor nystagmus. Matthew is 9 years old with visual acuity measuring 20/60. Jonathan, whose normal retinal photograph and OCT are included and are seen in the slide, is 15 years old with visual acuity measuring 20/40. They both have a conjugate horizontal pendular nystagmus, but the remainder of their ocular examination was otherwise normal. So Matthew's results are on the left and Jonathan's results are on the right. So for each sibling, I have included the flicker response from the left eye, which is seen as the bottom tracing. The amplitudes are reduced compared to normal. However, the amplitudes are above the 5 microvolt cutoff that I like to use as a marker for cone dysfunction. Implicit times are also normal for both kids. This suggests healthy cone function. The top 2 graphs demonstrate the dark adapted results. For Matthew, the left eye shows good response to dim light stimulation, suggesting good rod function, and a healthy 3.0 candela flash response, suggesting a good combined rod and cone response. Similarly, Jonathan demonstrates good bright response in the right eye, suggesting good combined rod and cone function. Signal interference is seen in a few tracings. I have been told that the new software update will improve some of these noise filtering algorithms. So with children or patients with nystagmus, sometimes using a combination of results from more than one testing session, more than one eye, and in this case, 2 siblings can be used together to establish a conclusion. In this case, 2 siblings with nystagmus demonstrate good cone and rod function based on ERG testing and help support a diagnosis of congenital motor nystagmus. The majority of nystagmus-inducing retinal disorders of childhood, including achromatopsia and Leber's congenital amaurosis, involve cones. One exception would be congenital stationary night blindness. Each cone flicker recording is usually performed over 10 seconds, requires no dark adaptation, and can be performed with the patient previously exposed to typical room light. As seen in the previous case, the ability to measure a good 30 Hertz flicker ERG can be helpful in ruling out certain causes of nystagmus. So again, I might stop here and see if there's any other questions before I move on to the next case.
Sure, Dr. Pegado, I have a question from Gerard DeWitt. If light adaptation is done by room lighting, do you have a controlled amount of illuminance, and is the room specially designed for adaptation, i.e. Near all white walls and light floor?
So yeah, not really, to answer that question. So the room is just a standard room with standard lighting, but before the test is performed, the patient is looking at within the Gansfield probe for a certain amount of time, and you can change that time depending on like how long you want to set it. But so if you're doing your light adapted test and the patient is staring into the Gansfield probe, they will be receiving uniform lighting and stimulation for that portion of the test. Some of these things get difficult when you're doing the test on infants, but when you have an adult, you can light adapt them appropriately using the Gansfield unit, even if you don't have a room with perfect lighting.
Dr. Pegado, I had a question with regards to reference data for dark adaptation, and actually it was kind of a question I thought I might be able to answer. So the question was, do we have reference data for dark adapted or scotopic tests? And in our new software release, which just took place in the last few weeks, we actually do have reference data that allows you to compare your results in dark adapted tests, as well as we've always had reference data for our light adapted tests. And so I thought I'd just answer that question, if that's okay.
Yeah, that's great. If my memory serves me correct, I believe the reference data on the ERG device goes down to 6 years old. But I might be off by a year or two there. But it's a lot more impressive than what you see with an OCT, which has, it starts usually much later than that. So yeah, it's helpful.
Yeah, I believe it's 4 is the lowest that we go. So do you sometimes use that 4-year-old data when you're dealing with patients who are younger?
I think when you're first starting out using the unit and like you have no sense of what's normal or abnormal, that reference data can be like very helpful. But then after a while, yeah, you start just having a good understanding of it. And then when you start doing the tests on younger kids, and I find myself doing it a lot on children that are under 4, then yeah, that data is not there, but you can kind of create your own in your head.
Excellent. So no other questions, so we can just move on to the next case.
So case number 3 involves a 2-year-old boy with a conjugate pendular horizontal nystagmus and reduced visual acuity measuring 20/150. Retina imaging demonstrates an abnormal appearing macula on the left. The dark adapted 3 candela flash ERG demonstrates a classic electronegative waveform pattern, where the right eye's B wave does not get back up to the 0 microvolt baseline, and the left eye barely gets up to that 0 microvolt baseline. So again, this is a classic electronegative ERG response. So the electronegative ERG is characterized by a normal A wave and a diminished B wave. The intact A wave indicates that the photoreceptors are functional. The diminished B wave indicates that the bipolar cells are not functioning normally, and that there may be a transmission problem between the two. The differential diagnosis includes X-linked retinoschisis, congenital stationary night blindness, Refsum disease, Batten disease, toxicities, birdshot, and melanoma-associated retinopathy. Once we see the OCT, the diagnosis is quite obvious. We have these bilateral retinal schisis cavities, and then we learn about the family history of retinoschisis. Yeah, the diagnosis is a no-brainer. But not every 2-year-old is cooperative for an OCT like this patient was. With this patient, the ERG was actually obtained several visits before the OCT was obtained. So X-linked retinoschisis is a rare congenital disease of the retina caused by mutations in the RS1 gene. The split within the retina occurs predominantly within the inner retinal layers. The photoreceptor layer is intact, hence the normal A wave. The disruption of the inner retinal layer results in abnormal bipolar cell function, resulting in the reduced B wave. It all makes sense. We've already discussed this patient's lack of rod system function, so let's look at the cone system with the flicker ERG. The response is very small, well below the 95th percentile reference data range. This is indicative of cone bipolar dysfunction as well. The power of the RETeval unit can sometimes be reinforced by observing how it stands up to the benchmark standard IS-CEV recordings done with a contact lens or DTL. Here you can see how the electronegative dark adapted ERG in our patient compares with the textbook result. They're almost identical. Similarly, the 30 Hz flicker ERG is expected to be reduced in X-linked retinoschisis, and this figure compares the reduced flicker ERG in our patient to a textbook case. If we had used a contact lens electrode rather than a lid electrode, we would expect slightly stronger amplitudes on our flicker testing. In summary, X-linked retinoschisis was well diagnosed with the RETeval, and results compare favorably with classic textbook ERG recordings. The electronegative ERG pattern is a useful finding with a narrow differential diagnosis. Non-sedated ERG testing was performed reliably in a 2-year-old patient with nystagmus. Many patients this age are not capable of having OCT testing, making the ERG results that much more valuable. So this case continues. Our patient with X-linked retinoschisis was started on oral acetazolamide and topical carbonic anhydrase inhibitors, just to see if we can make some difference in the retinoschisis cavities. The improvement cannot be appreciated by simply measuring his visual acuity. Every time this 2-year-old comes by and we measure his acuity, he's 20/150. However, an improvement in the flicker ERG amplitudes, although slight, can be observed over time. So September 24, 2019 is before the patient was started on any medication. He was started in February, and you can see that the flicker ERG has slightly higher amplitudes in March, and again, slightly higher amplitudes in April. And this is all ongoing stuff. These were just done like a month ago. So I previously showed the functional improvement over time using the ERG. Here you can see the OCTs demonstrating anatomical improvement. The RETeval was helpful as it was able to diagnose the disease and measure improvement over time. Okay, I might stop for questions again, see if there's anything out there.
Yes, Dr. Pegado, there's a question. How often would you do the repeat ERGs for this particular patient? Because they noticed that you did it in March and then again in, February, March, and April. Would you continue doing it every couple of months just to see how things are progressing?
Yeah, I don't think I'll be reimbursed for doing the ERGs as often as I'm doing on this one patient. Usually on a regular patient, we'll do them once or twice a year max. This case is different because he's on this interesting therapy. We don't know if it's going to work. His vision can't subjectively be recorded. He's 2 years old, so on a good day, he'll tell me his vision is better. On a bad day, if he's depending on his mood, he'll say his vision is worse. Like, there's so many factors when you're testing the acuity of a 2-year-old, and that's where I really like the objectivity of the flicker ERG. I want to know if I'm doing this patient any good with this therapy, and if I'm not doing any good, I want to get him off it. And if it is working, then yeah, parents are keen to stay on it, and they can see the improvement. The OCT again also sheds some light on the improvement, but it tells us about the structural improvement. It doesn't tell us about the functional improvement. There aren't that many tests of functional functional tests of visual acuity. There's some, maybe a PET scan or something, but there's practical ones. This might be it.
There's another question that's kind of with that theme. Did the parents note a subjective improvement in the child's vision?
No, practically when I see this kid, he's 20 over one. He's been 20 over 150 all the while. I think anecdotally, mom may have said that the vision was improving, but I don't know. Sometimes they're looking for something, and the kid's also getting a bit older, so So I think mom did tell me that she noticed some improvements, but I don't, based on just the Snellen acuity or the optotype acuity that I do in the office, I can't see the improvement yet. But I don't know, maybe it'll take a bit longer. I think the benefits of this medication aren't, it's actually quite unknown, so we'll have to see.
Okay. There was another question. Is the device compatible with all types of electrodes, skin or sensor strips, DTL, ERG, jet, so on and so forth? I think earlier in your presentation, you showed it using the jet electrode, right?
Yeah, it's incredible. Yeah, so there's no proprietary interface. There's a special one for the eyelid electrode, but the unit also allows you to hook up like a DTL electrode, the standard jet contact lens electrode. I haven't tried all of them, but just looking at the menu screen, there's several electrodes listed. I think you could probably use any electrode, as long as you could connect the two ends of the machine and the electrode.
Yeah, that's correct. I mean, there are
versatile.
3 connections. Yeah, it's a positive, negative, and ground connections. So you can connect to, like you said, there's a large selection of electrodes that you can use. Do you have, this is a question about do we have different sized sensor strip electrodes? Currently, we don't. How do you handle that if you've got a very young child or a young child that is maybe having a little trouble with the sensor strips? How do you deal with that?
So later on, I'll show a couple pictures of a newborn that's like a day old or a week old having an ERG test with a lid electrode. It's a little bit oversized for their face, but it works well. As long as the recording aspect of the sticker is located below the eye and is centered appropriately and makes good contact, it doesn't really matter where the other electrodes are, as long as they're making contact with the skins. So the way on an adult, when you put this electrode on the face, the temporal aspect of it would land on your cheek, but on a baby, because their face is smaller, the ear might get in the way. So you might have to move the sticker a little bit up or a little bit down to get around the ear. But I think there's plans in the works for smaller sized pediatric electrodes for these infants. And you could also use, if you had to use it, you could use a different electrode, I suppose, and that would work.
Mm-hmm. I think, one last question for this particular case before we move on, and it's kind of more of a comment, and maybe you can kind of respond to this. The comment was OCT is very important in such a case, as ERG is compatible with complete form of X-linked congenital stationary night blindness. Would you agree with that statement, Dr. Pegado?
Oh yeah, for sure. I think having an OCT is invaluable, 100%. It just sometimes to get an OCT in a 2-year-old would often require like a general anesthetic, and we're lucky, like in my office, and then with good luck and a certain patient, we're able to get an OCT on this child. But not every 2-year-old can do this. So there's many scenarios where you have a 1-year-old, 2-year-old, or even a 3-year-old where, unless you're willing to put the kid under general anesthesia, you can't get this imaging done. And then a lot of centers don't even have an OCT that can be done in an operating room. So then it's a matter of just waiting until they're old enough to get those scans. But for sure, in a patient that allows you to measure an OCT, the information is very important.
Okay, I think I have one other question, but I think it might be better kind of that we handle this one at the end. So I'll move on to the next slide, if that's okay for the next case.
Okay, so this is a 4-year-old boy with unilateral reduced vision. Visual acuity measured hand motion in the right eye, and 20/20 in the left eye. He demonstrated an RAPD in the right eye, and he has a 15 prism diopter esotropia. His retinal examination demonstrated diffuse chorioretinal atrophy and optic atrophy in the right eye. This was presumed not to be a retinal dystrophy because of its unilateral appearance and asymmetry. However, as you know, unilateral retinal dystrophies have been reported rarely in the literature. This child was presumed to have some form of neonatal insult in the right eye, presumably a chorioretinitis of some sort. In this child, there is a clear dark adapted ERG response in both eyes. However, the response in the healthy left eye is twice as large, while the timing is roughly the same. So the implicit times are about the same. Remember, the dark adapted bright light flash is generated mostly by the combination of rods and cones, but mostly rods. The reduced amplitude in the right eye is consistent with roughly half the rods being non-responsive, while the half that are responding seem to be operating normally. The latency is a sign of the photoreceptors being stressed, and the symmetry in this case between the two eyes is striking, with the B wave latency measuring 35.5 milliseconds in the right eye and 35.7 milliseconds in the left eye. This further suggests that the few retinal cells functioning in the right eye are not under continued stress. Also notice the difference in pupil size. This is in the dark with only a fixation LED on, but it looks like the right eye isn't perceiving as much light and therefore has a larger pupil. The flicker response shows the same features, meaning the cone system is similarly affected. The amplitude is roughly half in the right eye, while the timing is about the same between the two eyes. The pupil size shows a more pronounced anisocoria in this lighted scenario, again suggesting that it is not perceiving as much light as the left. All is consistent with fewer retinal cells participating in the light response, but the cells that are functioning appear to be healthy and not stressed. To summarize this case, reduced ERG amplitudes in the right eye suggest dysfunction of the retina and previous cell death and correspond with the reduced acuity in that eye. Normal ERG waveforms in the right eye suggest that the retinal cells that can respond are functioning normally. The normal implicit time suggests that there is no ongoing retinal stress to the remaining photoreceptors. The healthy and strong results from the left eye reinforce that the retinal function in that eye is normal. ERG is one of only a few objective tests of visual acuity as mentioned earlier. In this case, serial flicker ERG tests can be helpful in measuring subtle changes in vision over time. This contrasts to what we usually do in the office when these patients are examined, and we simply measure visual acuity at counting fingers or hand motion over and over again. In other cases, it also allows for objective acuity testing over time in patients who are unable to communicate or too young to communicate. So again, I might stop and see if there's any questions about this case.
Sure, Dr. Pegado. It's kind of about this case, but it's more of a general question. The audience member was asking, how many ERGs do you perform in a month, and how many of them are, valid, or do you consider valid versus not valid?
Yeah, so it probably depends on the month. The last 2 months, it'd probably just be that one kid with the Retinoschisis because I haven't been doing all that much. But in a typical month, on pediatric patients, it's hard, maybe, I don't know, 6 to 10. It's hard to really, I can't exactly get my numbers around it because I see a mixture of adults, and adults are also eligible for this testing. They seem to come in waves. And so sometimes you get a bunch of these patients with nystagmus, or you have a kid with diabetes, or a cataract and you want to assess the vision behind the cataract, and then there'll be a whole bunch of tests and you'll find yourselves doing like 15 of these in a month. And then there'll be another month that's a bit slower and you'll be doing maybe 1 or 2 a week, but it varies. But over time, I've done like hundreds.
Okay, great, thank you. This one is it's not related to the case, but it is a question with regards to, if you do a full ERG with a DTL, will the waves look the same as with the sensor strip?
No, so the way the sensor strip works is, so it uses this signal averaging to tidy up the waveforms, but when you use a DTL or like a jet contact lens electrode, you'll get like even cleaner recordings. There's less interference and the waveforms will be taller and stronger. So you'll be able to see, like, the information that you'll get will be even stronger, but it's just not as practical. Adults can tolerate it, but children rarely tolerate that kind of thing.
Do you see a correlation between the waveforms, between a DTL and a sensor strip? I mean, they're the same, but they're just different in amplitude?
Yeah, we had that slide earlier that kind of showed that, but I remember that picture of myself with the jet contact lens electrode. I did that. So the reason I did that is I wanted to see if the eyelid tracing was comparable to a contact lens tracing. And that was when I first got the machine, and it's remarkably similar. But maybe I'm a cooperative patient and I'm easy to test. But on a healthy, compliant, good patient, rarely, you don't really need to use a contact lens, and the recordings are almost the same. When I have a patient that has a known history or a family history of retinitis pigmentosa or some other retinal dystrophy, and they're an adult and they've had inconclusive testing, those patients I'll bring back and use the contact lens and then dedicate like a good amount of time, 45 minutes, sometimes even longer, to do a full like 6-step ISCEV test. Those patients usually have done a quicker eyelid testing in advance just to figure out if something was abnormal. But I don't do the long testing as often, but when I want to and when I need to, the machine's capable, which is amazing.
That's great. So no further questions on this case. Maybe we can move on to case number 5.
Okay. So, this is post-COVID. You can tell because my staff, the pre-med student, is wearing gloves and a mask. Here we have a baby who I had to examine because of retinopathy of prematurity, and this baby was born 16 weeks premature, so didn't have retinopathy, didn't require laser, but the retina is not fully mature. So I'm still examining this baby, and I'm a bit anxious that they might end up with something later on, but so far everything's fine. So anyways, I did an ERG on this child just to see what their results were, and parents were keen. As you can see, testing can be done on a non-sedated baby, and I don't know, the baby seems pretty happy there. My office actually prefers examining babies this age compared to 2-year-olds who have like better defense mechanisms. They can push you away and scream and move a bit better than a baby. This is the ERG response from our premature baby. Testing was performed with the eyelids closed. So it would be a bit much to try and put a speculum in their eye, but you can get meaningful data without. So it is possible to do an ERG or VEP while the infant sleeps without opening the eyelids. The eyelids will transmit perhaps 10% of the light. The light will also have a red appearance because it's going through the lid. So you might need to increase the stimulus brightness to get a good response. The settings on the RETeval are customizable, so you can talk to the company, and I've done this before, and ask for a custom setting so you can crank the light stimulus so that if you have a sleeping baby, you use the sleeping baby setting and you can increase the candela stimulation. Anyway, accordingly, amplitudes will be reduced when testing children with closed eyes, but abnormalities in implicit time should be minimally affected by having the lids closed. So the flicker ERG shows some response, albeit much delayed. Premature babies or children exhibit longer implicit times, and this is well understood. And this is measured based on the 30 Hertz flicker ERG compared to controls, suggesting that premature babies, ROP babies in particular, have abnormal cone function within their retinas. Here we have a picture of a baby, the same one, having a visual evoked potential test. They seem quite content. They're not screaming their heads off. There's soothers in their mouth. So we're not, I think an ROP retinal exam causes way more anxiety and stress and distress than this. One electrode, which measures the response itself, goes over the primary visual cortex, slightly above the inion at the back of the head. Another electrode is placed at a reference location, typically on the forehead or top of the head. And the third electrode for grounding in adults or a more compliant child would go on the ear. Here I place it on the temple. So these are the results. This is a young baby. Their visual system is still developing. You don't expect perfection with this type of measurement. The flash VEP, here you're looking for any kind of response between 100 milliseconds and 150 milliseconds. This baby was born premature and again is still undergoing screening for retinopathy of prematurity. As they get older, we would expect the VEP recording to become increased and more mature and more refined.
So, Dr. Pegado, I have a question from earlier, and I thought I'd kind of leave it until you reviewed the ROP case. Do you have a protocol that you use for different stages of ROP evaluation? Say, for example, stage 3, 4, 5.
So the truth is, I actually don't use the RETeval standard on screening babies with retinopathy of prematurity. I think this baby was probably the second time I've used it. And then part of that came from reading some of the research when I was assembling this presentation about abnormal ERG signals and increased latency seen with these babies. And I thought, really? I want to check this out. I want to see if it's true. Do these babies really have this? And does it persist with them later on? And yeah, lo and behold, they have it. So do I think I'm going to carry this RETeval unit to the hospital with my ROP screenings? I think the nurses would lose it if I did that. So yeah, I don't plan on doing that. But when a kid has unusual acuity or delayed visual maturation, or if something seems off about their system, or on these really, really premature babies, where I'm a bit more stressed about them, I think I might incorporate it. And again, if they're like not having any of it, if they're not impressed with the stickers and not having a good day, I'll just back off and nothing lost. But yeah, I don't have a protocol for different ages because I don't really use it standard on ROP screening.
Dr. Pegado, you mentioned increasing the light setting when testing through the lid. So do you have a preferred setting, 10 candelas or larger if you're testing through the lid?
Yeah, so because of that 90% reduction in light going through a closed eyelid, I typically look at the 10 candela response, and I use that as my medium light. So normally I would kind of pay more attention to the 3 candela setting, but in a baby with a closed eyelid, I'd probably skip looking at that result and use the 10 candela more. And again, if you wanted to increase the brightness, LKC could do that for you. They could give you a custom setting with even increased brightness. I'm just afraid of, I don't want to have the kid open their eyes accidentally and get this really bright stimulus if not necessary. But and I think babies' eyelids probably let more light in than an adult lid, just because it's going to be thinner. So that 90% reduction, I think that's in adults. I think in kids it might be closer to, like, I'm just making this up, but it could be like 60% reduction or something.
And I had another question. When you screen, if you are screening a baby with their eyelids closed, and how accurate do you find the flicker test to be? Just because there's no light adaptation with that patient, is it more directional in nature, or how do you find the flicker tests? And I can go back to those previous slides if you'd like.
So yeah, with doing a flicker test on a child with a closed eye, yeah, the amplitudes are going to be less. But sometimes these children, and many of you who examine little babies will see this, that they don't have a great Bell's response, or they're still peaking a little bit, and so those ones will get a little bit better stimulation from the unit than someone that has a completely closed eyelid. But regardless of the amplitudes, I mentioned this earlier, the implicit time is rather consistent between a closed and open eyelid. So again, that gives you a sense of how healthy the retinal cells are. So if you have a normal or a quick implicit time, it usually suggests that things are pretty good. So, but if you have abnormal implicit time and reduced amplitude at the same time, then I would be a bit more anxious and worried. And if you're really worried, I have done this infrequently, but there is the option to do this with some sort of sedation and perhaps have a speculum placed. Or if you're, I thought that if I was going to bring one of these kids in for surgery, then yeah, it'd be pretty easy to just do an ERG, a quick one before or after the case starts. But I haven't had to bring these kids into the operating room for sedation just because the unit is so well tolerated. But yeah, just getting back to the eyelid comment, I think looking at the implicit time becomes much more important when you have a closed eyelid.
Sorry, Dr. Pegado.
Sorry.
So you mentioned earlier in your presentation how your staff sometimes likes dealing with babies that are this young, but you did mention that you may sometimes have 2-year-olds that are uncooperative. What type of test, if you had to do a test in a child who is uncooperative, generally what kind of test do you use?
Oh yeah, so the RETeval has a couple like pre-designed quick tests. So the most common one would be a flash then flicker, or a flicker then flash. So this just gives you the quick 30 Hertz ERG, and which tests your cone function, and then you get your 3 candela flash ERG, which gives you that general waveform. And so you might not have all the different 3 or 4 versions of dark adaptation, but you have a very quick sense of whether the child is normal or abnormal. And that's well taught. You can do that within minutes. You don't have to dark adapt if you don't want to. You can if you choose to. And yeah, I think under 5 minutes, you can have both eyes done. And if you have a screaming 4 or 5-year-old kid, I've done it myself. My staff have learned how to do it. They're moving their head all around, they're screaming, and you just move the RETeval unit with them as they're crying, and eventually the test is done, and you take it away and they're happy. So yeah, it's a bit of a game. I think even the staff aren't stressed out about it. They can do it. Obviously you can't move an OCT around and follow a kid that's screaming, but yeah, the RETeval does.
So these other 2 questions are kind of related to that. The one question is it possible to stop and record the exam with just a few acquisitions and not the total number of responses that the procedure is programmed to acquire? So actually, if you don't mind, I can answer that one. Our
Sure,
new firmware.
I can answer something after you answer too.
Sure. So the new firmware that we have allows you to do that. So if you have an uncooperative child and you just get a few acquisitions, you don't have to wait for all of the responses in order to see the results. So that's a nice new feature that we have with the new software release.
And with the old software, even if you did abandon early, you could print out what you had. So if you only got the right eye done, or if you got the dark adapted in 2 eyes and the light adapted in 1 or whatever, then it would still allow you to save what you had. With the VEP testing, it was initially, when I got the machine, it was based on an adult protocol, and it would take forever to go through all the runs. And so I talked to LKC, and they gave me a custom protocol that's a lot quicker for obtaining VEPs. So yeah, the machine, I guess the new firmware will allow you to do some of that customizing yourself, but if not, I think the company can adjust the settings for you quite easily, which is amazing.
The OCT, the question about the OCTs that you had in your presentation, is the one that you use a standard OCT or a handheld?
No, I don't have a handheld OCT, just a standard like desktop mounted big unit. The one I have requires a photograph and an OCT at the same time, which I find quite helpful with kids because you might only get one shot with them. And sometimes when you're using these devices, the OCT doesn't have a flash. So when I'm imaging a child, often, well, the staff have learned this very quickly. They'll do the OCT first because the kid doesn't get upset. As soon as they get hit with that first flash, sometimes you don't get the second eye done.
I see. Okay. This question came about the new software release. So if you currently have RETeval and you would like the software release, we'll send out an email with the location on the website where you can download the new software release and with the instructions on how to update your RETeval device. So I'll send that out to everybody who attended. So in the interest of time, I know you have one other slide that you wanted to present. You mentioned that you had primarily a pediatric ophthalmology practice, but that you did do some general ophthalmology. So I know you wanted to mention that you do use the RETeval in other areas as well.
Yeah, so if you have a mixed practice, or if you have an adult practice only, there's lots of potential uses for the RETeval. The RETeval has a very interesting protocol called the DR protocol, which I found quite useful and quite reliable with diabetes. So it looks at the implicit time and the amplitudes of the flicker ERG, and it's quite sensitive for retinopathy. Anyways, but yeah, cataract, glaucoma, vascular occlusions, macular degenerations, drug toxicity, VEPs, and optic neuritis. It can be very helpful for those for nerve conditions. Any condition where you can't get a view of the retina, the light can usually get through. And so if you have a cataract and vision is 2200 and you want to know, is it worth operating on this eye? What kind of function is behind there? You can do an ultrasound to see if the retina is intact, but do you actually get a sense of whether there's any reasonable retinal function? Not really, but if you do an ERG and you get a decent flicker response with normal implicit times, your amplitudes are going to be down because the light will be reduced. But if your implicit times are normal and you have a decent waveform, it can tell you that there's better retinal function there than you would have otherwise thought. So lots of uses for adults, but I'm biased towards the pediatric uses.
I had one last question here, which maybe we can squeeze in. Do you see much pediatric glaucoma? Do you ever use this device in pediatric glaucoma?
I do. So I have a reasonable amount of pediatric glaucoma in the practice. Probably, yeah. And so visual field testing, as you know, is unreliable in children. So having an objective test of visual function, aside from Snellen acuity, can be helpful. So yeah, repeat ERG testing. I do repeat ERG testing on kids with glaucoma that are not capable of doing visual fields. And actually, sometimes I do it on patients that are capable of doing visual fields just to get more information, because yeah, the more information, the better.
Great. Well, thank you very much, Dr. Pegado. We really appreciate your time today. We're just a little bit over, and thank you very much to the audience for attending the talk today. I have one last slide I just wanted to present. So if you have any questions or need any more information with regards to the RETeval, please feel free to reach out to myself or Monica Ranta, who I didn't put on the slide. Monica, sorry about that. Monica is our VP of Sales for our international division. I'll send out her information as well. Or if you're in the US, we also have our US distributor, Conan Medical, and Ian McMillan is our contact there. We know that it's a difficult time now, and people are, reluctant to purchase new equipment. There is a special financing deal that we have on in the US right now, which allows for no payments for the first 6 months. reduced payments for the following 6 months, and then payments starting after that. So this will hopefully allow people to put the RETeval device within reach, be able to start treating patients right away, whereas not having to worry about cash flow issues. So once again, I'd just like to thank Dr. Pegado for his time today, and thanks everybody for attending. This presentation was recorded and will be placed on our YouTube channel, on our website, and if you'd like to refer back to it, it'll be there in the next couple of days. So once again, thank you very much, and have a pleasant day, pleasant evening. Take care.